Hi, I'm Jason Barker, and this is my lecture on intravenous fluids. This lecture will be aimed principally at medical students, as well as doctors who may be starting on the ward or other healthcare staff who may need to give intravenous fluids. As a brief disclaimer, this is not meant for medical advice. If you have any medical concerns, please consult your primary care physician. So, for the aims of this lecture, I want to answer the question of why we use particular intravenous fluids. Why would we use one over the other? How do these fluids differ in terms of the molecular components that constitute them? And finally, what physiological parameters would influence our decision to use a particular fluid over another? I'll also attempt to go into some of the controversies regarding intravenous fluid use. So, why would we give intravenous fluids? The first reason would be simply maintenance. Now, we all have a certain amount of oral fluid intake every day that are required for normal physiological functions to continue. However, some patients, for whichever reason, might not be able to receive normal oral fluids. Now, this might be patients who are nil by mouth for a surgical procedure. It might be patients who have just recently had a surgical procedure, such as bowel resection. Or it could be for patients who are just very confused or unable to have a safe swallow reflex. The next major reason would be fluid resuscitation. Now, this is to restore a loss in circulating volume. There are several reasons why the circulating volume may drop. This could be, for instance, due to a fluid shift outside of the intravascular compartment, secondary to something like ascites, for instance, or perhaps they just have widespread edema. The other reason would be to counteract fluid loss. Now, this might be in patients who have loss of blood. This may be for patients who have diabetes insipidus, and therefore they're excreting massive amounts of free water, and it may be via patients who have diarrhea or vomiting. Finally, it may be that the patients need fluid resuscitation just because of a very low intake. For example, in late-stage dementia, this is quite common. Or it may be a patient who's had a fall at home, they've been left lying for many hours and they come in substantially fluid depleted. Finally, the reason you might give intravenous fluids isn't to replace fluid loss per se, but rather to correct electrolytic imbalances, which I'll go into later. So, as a very brief reminder, it's worth noting and worth committing to memory that in terms of the potassium and the sodium, people need approximately 1 millimoles per kilogram per day. And secondly, there's a very simple equation to calculate the overall amount of fluid that is required in terms of maintenance. And that equation is simply 30 milliliters per kilogram per day, meaning that an adult 70 kilos will require 2.1 liters of fluid daily, whereas an adult who is, say, 100 kilos would require exactly 3 liters of fluid. A very important concept to understand in the context of fluid movement throughout the body is the Starling hypothesis. This states that the net filtration, i.e. fluid movement from the intravascular space outside of the vessels, is dependent on essentially a gradient between what we call the hydrostatic pressure as well as the oncotic pressure across the capillary. To summarize this in a more simple way, if you can imagine, the hydrostatic pressures are essentially the pressure within the vessel, which push fluid outwards and therefore encourages transudation. The colloid oncotic pressure is the converse of this. This force maintains fluid within the intraluminal space, and this is driven by the concentration of membrane impermeable molecules. For example, in the human body, the most common of these is albumin, and this applies to all mammals. And therefore, the net fluid movement is determined by the balance between the colloid oncotic pressures as well as the hydrostatic pressures, with the increased hydrostatic pressure encouraging movements from the intraluminal space into the interstitial space, which is called transudation, whereas the colloid oncotic pressure is going to pull things backwards and maintain them in the intravascular space. Now, how does this relate to the administration and selection of intravenous fluids? The next concept to understand is the relative distribution of fluid within the different compartments of the body. Usually, at the highest level, fluid is divided into two compartments. You have the intracellular compartment, which comprises approximately 2/3 of total body water, and then you have the extracellular compartment, which comprises 1/3 of body water. The extracellular compartment includes the fluid that's contained in the plasma, and of the extracellular compartment, the plasma is only 1/4 of that. So remember, most fluid is not located within the intravascular space, and in fact most of it is within the cells themselves. Next, it's important to distinguish between two different types of fluid. These are crystalloids and colloids. Now, what distinguishes these types of fluid? So, a colloid is defined as a solution which contains molecules of a large molecular weight which do not pass freely through healthy capillary membranes. In contrast, a crystalloid is essentially the opposite. It contains only small molecular weight solutes, such as, for instance, sodium and glucose. Conversely, these pass freely through the membranes. Now, how do crystalloids and colloids relate to the previously discussed Starling hypothesis? So, in principle, colloids, due to their large insoluble molecules, have a higher oncotic pressure. And as you recall from the previous slides, a higher oncotic pressure causes more fluid to be pulled or to be maintained in the intravascular space. And therefore, on this principle, you would expect colloids to distribute more into the intravascular compartment, and therefore be superior in terms of resuscitation due to being able to maintain the fluid within the intravascular space and therefore maintain the blood pressure. However, it's a little bit murkier in actual clinical practice. There have been quite a few systematic reviews done over the previous few decades, and the pattern really is that they haven't established any significant difference in the efficacy, despite the physiological differences between the components. Now, this is quite a controversial topic, but in general, crystalloids are widely used in the hospital, and I've had very little experience in prescribing colloids, with the exception of human albumin solution, which can be used in gastroenterology, particularly following pericentesis. Furthermore, there is a higher risk of allergies in colloids as compared to crystalloids, although the difference is not all that substantial. However, as I said, crystalloids are far more widely used in clinical practice, and as a clinician, you're naturally going to get a lot more familiar with the administration of crystalloids than colloids, and most of this lecture will focus on the use of crystalloid solutions. So there are a number of commonly used crystalloids in clinical practice, and I've put a table up just so you can pause and maybe just go through them and just get an idea of the differences in terms of their molecular constituents. So the most commonly used in hospital settings are 0.9% normal saline, as well as Hartmann's solution, at least in the UK. Also commonly used is 5% glucose, which is mostly used in the context of maintenance fluids, as well as lesser concentrations of sodium chloride, often with glucose, which may be used in pediatric circumstances. So the first fluid to discuss would be 0.9% normal saline. Now, in my clinical experience, this is the most widely used crystalloid by quite a substantial margin. So this is an isotonic fluid, and it's a crystalloid. As a crystalloid, you would expect approximately 25% to be going into the vascular space. However, compared to plasma, it does have quite dramatic amounts of sodium and chloride, as you'll be able to see from the table. It also has a pH of approximately 5.5, which makes it quite acidic. Looking through some of the discussion on normal saline, although in vitro it is acidic, pH 5.5, in vivo the acidity is normally quite easily offset by the physiological buffer systems, although there is some evidence that it effectively dilutes the metabolic buffering systems in the blood and therefore can contribute to a metabolic acidosis. The next fluid to discuss is Hartmann's solution, also known as sodium ringer lactate. This is another isotonic fluid, much like 0.9% sodium chloride, and as a crystalloid, roughly 25% distributes into the intravascular compartment. Where this differs in terms of its molecular makeup, especially compared to normal saline, is that it contains potassium. It also contains normal levels of sodium and chloride, and due to the large amounts of lactate present in it, which acts as a buffer, it has a neutral pH. This is quite excellent at restoring intravascular fluids and is widely used, especially in surgical settings. A circumstance in which you may want to consider not using Hartmann solution would be in hyperkalemia, due to the large amounts of potassium present in the fluid. Furthermore, if a patient has a lactic acidosis, then it would be expected that their LDH is already quite saturated, and therefore they will be unable to effectively reclaim that via the Cori cycle, and therefore it can exacerbate a lactic acidosis. So therefore, in patients, for example, with sepsis or mesenteric ischemia, or perhaps with lactic acidosis secondary to metformin, then you might wish to not use this particular substance. Another commonly used fluid is 5% glucose, also known as dextrose. This is, in contrast to the previous two fluids, a hypotonic solution, and therefore it's extremely poor at maintaining the intravascular concentrations, and therefore you want to avoid usage in any sort of resuscitation scenario if at all preventable. Just to give you an idea of how ineffective 5% glucose is in a fluid resuscitation role, you would need approximately 12 litres of dextrose to restore only 1 litre of intravascular volume. While 5% glucose does contain reasonable quantities of sugar, it's worth bearing in mind that it isn't able to provide the daily calorie requirements of an adult human, with approximately 1 litre containing around 150 calories only. And very briefly, I'll just go over some of the alternative forms of saline that can be given. So first up, we have 0.45% sodium chloride plus glucose. This is all together in one bag. This is usually given to children specifically for fluid maintenance, not for resuscitation purposes, and the reason that they have extra sodium chloride is that they have an increased risk of developing hyponatremia. Next, we have the hypertonic forms of saline. Now, I've never had to prescribe these myself, but from my understanding, they're most widely used in the context of cerebral edema. Either hypertonic saline or mannitol can be used for this basis, and the rationale is that because these have a higher osmotic value, what they will do is blood that is going into the brain will exert a higher oncotic pressure and will help pull some of that fluid back into the intravascular space and therefore reduce cerebral edema. The other circumstance in which hypertonic saline may be considered, although again, I haven't ever seen this in clinical use myself, would be in status epilepticus secondary to hyponatremia as an emergency measure. Now, when would you give fluids and how much would you give? Ultimately, the question is clinical in nature and will depend on all of the different clinical parameters, and it will be a question of judgment. However, there are some guidelines, specifically by the National Institute of Clinical Excellence, which suggest some of the parameters which would prompt you to consider giving IV fluid resuscitation. Now, the biggest of these would be the systolic blood pressure. In particular, if it's dropping less than 100 millimeters of mercury, you would consider it. If there's a sudden drop, you would be more concerned than if this was their baseline systolic blood pressure. And furthermore, the lower this is, the more concern you would have and the quicker you would think about replacing that fluid. Heart rate is another particularly important clinical indicator, especially in that it's quite frequently the first manifestation of volume depletion, and young patients are actually especially good at being able to maintain their blood pressure, and the heart rate will be the first thing to rise, and therefore it might be your best early warning indicator. Further to this, you could also assess the capillary refill, and if this is quite sluggish, then you might consider intravenous fluids. The NICE guidance also recommends if the respiratory rate is elevated, then you might want to consider fluid resuscitation. However, I would be careful of this, particularly if they have some element of pulmonary edema or pleural effusion, then you might be making the situation worse in this scenario. However, if they're dropping their blood pressure, spiking their heart rate, it's in the absence of any other given risk factors, it would be good to try a fluid challenge and see how they respond. So, in terms of the actual fluid resuscitation guidance, they suggest at first giving 500 milliliters of 0.9% saline or Hartmann solution. Obviously, you would consider their electrolytes in this circumstance and you would pick appropriately based upon the clinical circumstance. If the patient has heart failure, then it's good to go cautious due to the risk of pulmonary edema, and you'd probably want to go for a 250 ml bag. Give these quickly over a period of say 15 minutes and get the nursing staff to reassess this and then make further clinical judgments moving ahead. If you're a junior doctor and you find yourself having to give several fluid challenges, the patient's systolic blood pressure may come up and then it may drop again, or perhaps it's not coming up at all, then in that circumstance you'd want to get senior help. There are several pitfalls and considerations that you should be aware of when giving intravenous fluids. The first is whenever you're giving potassium, you do have to bear in mind that it is an irritant, and especially when given peripherally, it can cause quite significant phlebitis and pain in patients. For this reason, unless it's an absolute emergency, you should never give it at a rate greater than 10 millimoles per hour. Ideally, if you need to give the infusion faster than this, then you'd want to make sure that a central line is inserted. The next thing to watch out for is the risk of edema, and this will be true when giving any sort of intravenous fluids. For this reason, it's good practice to periodically reassess the patient, auscultate the lung bases, check their ankles, and just make sure that they're not becoming edematous. In conclusion, the effective prescription of intravenous fluids is one of the most important skills that you can possibly develop as a clinician. It's very important to be able to recognize patients who are volume depleted, to be able to effectively restore their intravascular volume, and based on the rest of their clinical parameters, to be able to select the intravenous fluid that will be the best suited for their situation. Secondly, crystalloids are more widely used than colloids, and the evidence does not show any increased effectiveness of colloids over crystalloids. And finally, just to reiterate the importance of this, fluid selection should always be tailored to the needs of the patient. Thank you very much. I've provided some references. If you have any questions, then please do ask and I'll try my best to answer. Thank you.